Well, good morning, everyone. Thank you for attending the SVForum Health Tech Breakfast Series today. We have a panelist who's actually delayed as a result of traffic, but will be here shortly. So Dr. Samir Kumar will be here. But I would like to introduce you to Greg Schaff, who's our moderator today with Nixon Peabody. So enjoy. Thank you.
Hi, welcome everybody. It's a really sincere pleasure to have SVForum here in San Francisco. I know that you meet most often down in Silicon Valley. It's terrific that you've been able to make it up here, and that we're going to be able to proceed as soon as Dr. Sam Kammer gets here with a full panel. But in the meanwhile, I will tell you just a little bit about myself, since I've been asked to be the moderator. I'm a business litigation partner with Nixon Peabody. I've been practicing for over 25 years. I have a specialty area in trade secrets, which is, frankly, is as close as I've come to any of the kinds of things that you all do. I've represented various medical service providers and products in the medical field in connection with trade secret thefts and issues that have arisen there, which is a fascinating area. Not the subject of what we've got today, but what we have today, as you know, is an extremely exciting kind of program. The panelists are entrepreneurs and pioneers in their field, as I assume most of you are as well. And I have to confess that I didn't know very much about this area at all when I was asked to moderate the panel, and I am just amazed at what's going on in the medical provider and associated fields here, and these new patterns and developments that are being discovered and initiated that will create new jobs, new opportunities, and new services, and new and better ways of keeping us all healthy and making us healthy when we're sick are just tremendous to me. I'm really delighted to be able to introduce two of our panelists at this point. First, Pam Swingley from Mobile PRM, a really exciting kind of business that she's put together. She's the CEO. It involves patient relationship management through mobile phones. And I'm going to let her introduce herself in a little more depth and tell you a little bit more about herself, and then we'll introduce John.
Well, good morning, and it's really nice to be here. And I started Mobile PRM really to help my father out in managing his medications. And we have a consumer product called Remember It Now. And it's built from the patient's point of view. And so my dad was having a hard time. He's 83. He takes 10 medications a day, staying on his medication schedule. And in addition, I realized I needed to be able to share his health information with my family members and with the caregivers and coordinate care. So it started out as a simple reminder system to the phone. And from there, it's grown into the idea that adherence isn't just about getting reminders, but it's about tracking your compliance and how well you're doing. It's about getting educational information related to your disease or to the importance of adherence. It's about being able to track biometrics and seeing how your sleep might impact whether you take your medications or not, or how well you feel overall. And so it's a combination of this feedback, and it includes a complete personal health record, which the patient owns and can share with the provider if they choose to, or with the family members. So there's the Remember It Now, and it's an ad-supported model. We also have Mobile PRM, which is patient relationship management, and the model there is to be sponsored by pharmaceutical companies or clinical trials, where you would use this to build a relationship directly with the patient and improve compliance and be able to have really 24/7 relationship with that patient. And so that's likely to be patients that are taking specialty drugs that are very expensive and complex to manage, and that you want that ongoing connection. So that's what I do. We're a very early stage startup. We are to market. We have 1,200 users that have randomly come to our site and use the product and give us feedback to make it better. and we're in the process of trying, or we will eventually raise some capital and grow, and getting our first trial with a pharma company. We're on the mission to get that done too. So we have some traction.
Great, great. Thank you very much, Pam. John McCready is the founder of Partnera. This is an organization that, a company that promotes better ways and more effective ways for provider organizations to interface with other organizations down the line, and ultimately with the ultimate consumer of healthcare services. And I'll let John explain in a lot more detail what the company's all about.
Right. Thank you. Partnera, as you said, works with health systems, and we think we provide a bridge from what they do, which is provide clinical help when there is a patient.
Should we, excuse me, should we use these microphones? Is it okay with that? Prefer them?
Would you rather have this, or could you hear me before?
Sounds kind of sexy.
I think we probably better use, there you go. I think we got people in the back. It might be harder to hear. That's great.
So what we hope to do is provide a bridge for a health system to reach the consumer before they're a patient. To give you some context about that, everybody knows the health systems in town, but probably only 10% of a typical consumer accesses those services. 90% know about them but don't use them, and of course that varies by specialty. We think that a health system needs to be able to reach their community before there's an event, and that's typically been something that they've relied on insurance companies or their physician referral base to provide them. And what we do is aggregate technologies, not too different than PAM. PAM would be a great piece of technology that we could aggregate and then distribute on behalf of the health system, so that the consumer starts to have a relationship with the health system before they're an acute patient. So I would say we're a technology aggregator and a service provider that takes the place of insurance services that typically would have to be acquired or purchased by a health system.
Terrific. Thanks, John.
I would say too that we just signed our first contract with about the 6th largest health system in the Midwest, and we're very happy to be out of the pre-revenue stage after.
Good. Congratulations.
Yeah, that's a big deal.
It's a huge deal.
Wonderful. Next, in an extremely timely fashion, is Dr. Sam Kamer, who is the founder of Medline, Inc., which is a subscription healthcare service, and he's a pioneer in again, these new kinds of ways that healthcare can be provided. And we're really pleased to have you here, and I'm glad you made your way through the traffic, Dr. Sam.
Thank you. I wouldn't be holding true to my doctorly habits if it wasn't late, but here I am. Thank you for having me here. I'll just go into a quick background about myself that might help me to explain where Medline came from. I'm board certified in family medicine, and I moved here from the East Coast about 6 years ago to open up the first VIP membership medical practice in Monterey. I still serve as Pebble Beach's house doctor, and that was great, but the economy.
TV shows after?
Not yet. In 2008, when the economy tanked, my wife, who's also a board certified family physician, had the traditional insurance-based type of practice, and we saw her numbers decline rapidly. And it wasn't long before we realized it was because of unemployment being at an all-time high in this great country. Employment is linked to health benefits, and if you have folks being laid off, they no longer have benefits. So we decided to use the legal expertise and the knowledge base we had for membership medical practices that we created for the discerning clientele and apply that to the masses. And so Medline was born. We're only about 1.5 years old, and we did it to just help our local community in Monterey. We realized we were onto something because we had really taken out the middleman. We had taken out insurance companies from primary care, which is big because most patients go to primary care visits 70% of the time during the year. And when you take insurance and insurance billing and the insurance cycle out of it, you save about 40% in overhead. We realized huge savings, started seeing revenue streams grow quickly, so we realized we were onto something, and we decided to look around the country. Well, very few others were doing this around the country. Many were doing concierge-type medical membership practices, but no one was doing what we call direct primary care. So we were the first ones in California to do it. We were always afraid of getting shut down by the Department of Managed Care because we could be misperceived as insurance, so we hired the lead prosecutor of the Department of Managed Care, and he is now on our team. In fact, as we speak right now, he is testifying in the Senate for a bill that is being introduced by Senator Harman to make these types of practices not so regulated by the Department of Managed Care. Big day for us today. Well, we opened up our second practice in Mountain View just under a year ago, just our second one, and it was to get on the map, to cater to investors and to see how we would do in a big city, continue to grow. And after that popularity, we decided to license out our model to physicians all around the country. We're growing at a rate of about every 3 weeks we grow into a clinic. We have licensed out the model. We're probably the fastest growing direct primary care company in the country. We are 100% privately owned, not by Uncle Sam, but Dr. Sam, and we'll see how long that goes. We're talking to a lot of investors right now who have taken notice of us, including some big companies like McKesson and Johnson & Johnson, but we're seeing what happens. Our goal is to license this model out into as many practices as possible. What do we do? In a nutshell, for $59 a month, we provide full spectrum primary care to our patients. That includes very low-priced doctor visits, as low as $10 a visit, big discounts on medications, reduced fees on imaging and labs. And so by removing insurance from primary care, we actually prevent overutilization of medical services and have been growing. There are not too many competitors around the country right now. I'd say less than a dozen, but they are coming up very quickly, particularly with the insurance industry sort of in the wings right now with the ACA and Supreme Court. We're in a very good position to grow. We are in Obama's healthcare plan. We have an amendment in there. We lobbied with our competitors' money, and we have Amendment 10104 of the healthcare bill, which allows us, when combined with wraparound catastrophe insurance, to actually compete with insurance companies on the health insurance exchanges. So whether or not the bill goes through, we're still going to be okay. We have a bright future, we think, ahead of us. But that's what we do in a nutshell. We've basically taken insurance out of primary care and putting it back where it belongs, which is basically for catastrophes.
Great. Thank you very much.
Could I say
Dr.
one
Sam.
thing?
Absolutely, John. Please do.
Dr. Sam, every time you said insurance, you turned and looked at me. I just want to make sure, that you're not painting me with that brush.
No.
Okay.
I thought he was looking at me. I also do a lot of insurance litigation. Not in the medical field, but I kept thinking there was some hidden text there as well. But I think we're fine. Congratulations to all of you. It's really a pleasure to have three really creative, dynamic people here. And I'm sure many of you have questions that you want to ask. We have a few questions that we're going to pose to the panel here first, which I think is the typical format for these, but please don't be bashful about interjecting a question if you think it's appropriate at any time. So we'll start with the first question, and then we'll make time at the end too, for sure, and I'm sure the panelists will be happy in any event to either stay, or if they have to leave, to give you their contact information so that you can follow up with them individually if you'd like to. With that, we'll start with the first question to Pam, if we can here. And this one is as follows. Can technology enable creation of new models of healthcare delivery throughout the entire care cycle? How's that for a softball question? Huh? Can it do that, Pam?
Well, we wouldn't be here today talking if we didn't all believe that that can happen. And so I can really speak to the patient-centric side of that, of course, and our solution empowers that in being able to manage their own care. It helps to bridge the gap after what happens when you leave the doctor's office, and that's really where the adherence falls down. Whereas if you've got this connection, thank goodness the smartphones came on the scene that provides this bridge and ongoing reminders, prescription reordering, sharing with your caregivers, sharing with your family members, single login to multiple accounts. Absolutely, technology is transforming it. Now, it's transforming it in bits and pieces because on the doctor's side, you're seeing your doctor with the iPhone tablet now who's collecting information. And I think, oh gosh, I forgot.
No, that's, I think it's better.
Can you hear me better? Did you hear me before though? Yeah, I talk pretty loud. It's kind of
See people in
embarrassing
the back
actually.
kind of-
And I think that if you're part of the Kaiser plan, that they're using technology very, very well. And when I talk to people that have Kaiser, all their blood work is there in their portal, and they're very excited about it. So it's happening. It's absolutely happening at all levels, different technology solutions. Our solution could fit in well with Sam's solution in extending that relationship out. The problem is right now it's disjointed, and I think we have a question about that technology. It needs to be seamless throughout that, and that will happen. It's like back in the old .com days when you had individual point solutions. These all will work together at some point. So we're very optimistic for where it's headed.
Want to comment on this, either of you?
Sure. We could definitely use technology in our model. Right now, the current system, the health system, is that doctors get paid when they see patients. Unless you see the whites of the patient's eyes, you rarely get paid by the insurance industry or even by the patients. In our practice, we get paid by the month. It's a membership fee. So we don't mind doing telemedicine over the telephone or through an app. We have an EMR system currently that is designed for direct primary care. We in fact give that to all our doctors to sign on. And we don't mind getting an email from our patient and treating the patient by calling in a medication, because if it prevents the patient from coming in unnecessarily, it would decrease the overutilization of medical services, over-testing perhaps, and I've been able to use technology to take care of our patients. Patients love it because they don't have to come in, and the doctors are happy because they still get reimbursed. I think it's a better system. I'm biased, of course, because I run a company that focuses on that, but I think that if a patient were to to receive care without requiring that patient to come in, that care is more accessible, and hence the patient is taken care of a little bit better. I also like Pam's company because it gives some accountability to the patient. I think that's very important. Many times the doctor is not always around, and if we can create technologies where patients under doctorly supervision or nursing supervision can take care of their own health using technologically advanced tools, that is a fantastic thing. We're a very advanced country in terms of technology, and there's no reason why we can't use that. Probably medicine is the most behind, and I think it's time that we catch up.
I personally think it's just absolutely terrific. It's only been within the last year or so, maybe a year and a half, that I've been able to email my doctor. I'm not in Kaiser, but in another plan, and get responses, get prescriptions renewed regularly, and reminders that they are to be renewed, and questions answered, and updates on when particular kinds of tests ought to be done, and I can view all of the results that I have. It's something that was a mystery to me before, and now at least I have the security of knowing as a patient that if I move to another provider, that whole history is available. And I know that's been an initiative that's been a part of the healthcare industry for years and years, and HIPAA and all these other kinds of privacy issues have gotten in the way to some extent, and this is great if it all works out. I know that there are hitches in this. John, did you want to comment on?
No, what we see is the great hope for technology, and we're big believers that technology will transform the industry. But we see this big gap between the people who know and love technology, the active users, are not the same population who might be able to use that to transform their health condition. So one of the things that we're attempting to do, again, we see ourselves as trying to bridge these things, is we've launched a program with Chicago Public Schools whereby we try and educate the student body around the technology so that they enter into the marketplace as a more informed consumer. I'll give you a factoid. You figure about half of the Chicago public school system, half of the students in that are Medicaid beneficiaries. And of that 50%, about 50% of them are either diabetic, pre-diabetic, or obese. So what we have, and I would argue, I don't know this to be true, but I would argue that most of those students are very technology literate. About every one of them has a smartphone. So the challenge is going to be, as we enter into this effort, is how do we transform a populace who isn't quite sick yet, but might very much need it to use the technology they learned to love, their smartphone, to be more engaged with their personal health. And I think that's kind of what we hope we can do for communities and for health systems, because the technology's there, using it, and using it appropriately is the heavy lifting, I think.
Terrific. Another one for you, John, as long as you've got the microphone here. The next question is not so much a softball, I don't think. The question is, how will the existing healthcare infrastructures from care delivery and management through reimbursement deal with the tensions between supply and demand?
That's why Sam kept looking at me on the insurance piece. Well, I happen to think it's a ground-up solution. I think what Dr. Sam's doing and what Pam are doing are exactly the right way. We have a mantra. We believe that access leads to engagement, that engagement leads to behavior change, that behavior change is what's required to transform the system. And when that happens, we'll get improved health and we'll get lower cost. So how do we get in front of that? Because the rest of it is the economic game of swapping dollars, and everybody wants to get paid for what they do. And I don't think there's anybody evil in that. But I do think that if we don't engage the consumer and say, we'll give you access to this stuff if you engage in a meaningful way to want to improve your health, that we'll not successfully manage a cost problem that's just unmanageable right now. Anybody will tell you we can't sustain the current economic model. It won't work, whether you're an insurance company, whether you're Medicare or Medicaid. It just won't work. And I think everybody's throwing some top-down solutions at it. But when one starts to say, hey, this is my problem to solve, can I access healthcare directly, and then worry about catastrophic support should something catastrophic happen to me, that's the transformational change we need to make as a culture. Because right now we're trying to solve it from the top down, and it's just too many. As a consultant once told me 20 years ago, there are too many of us ticks on the healthcare dog, and it just too many people make a very good living at that. And until we consciously transform that and say, let's engage the consumer with their own healthcare, then nobody who's trying to help, whether it's Dr. Sam or Pam, nobody's going to be able to help them because they think it's going to come down from some entity. That's just my take on it.
Dr. Sam has a thought, I'm sure.
I have lots of thoughts of that. The current system is unsustainable. That I think we all know. There are changes being made right now at a governmental level, at a doctorally level, at an entrepreneur level, which are all necessary. Insurance, I mean, as a culture, it's ingrained into us that health insurance companies will take care of us. That's not true. Health insurance is in the business of insurance. They're not in the business of healthcare. It's going to be up to entrepreneurs in the health field and doctors and hospitals to get into the healthcare business. Doctors make horrible businessmen, but we have to try. Insurance was never meant to take care of a sinus infection. It was really never meant to take care of the small bronchitis that you go and see your doctor for. Those are those are fees that are just being wasted. I had a patient, we were at an expo the other day in San Jose, and the patient said, well, I don't need you. Doctor, I pay $1,000 a month in Blue Shield fees, and I only go to my doctor once a year. My response was, wow, you must be quite well off. You're spending $12,000 for one doctor's visit. You have not been to the hospital in 3 years. That's a waste of money, in our opinion. If you could raise that deductible to a $10,000 deductible, because he can't afford to pay that, he's already proven it, and then combine it with a reduced fee system in primary care, he could keep his out-of-pocket costs low. We could take out the middleman from the primary care industry. The doctors make their reimbursements happily. Patients don't get robbed. They feel so, and everyone's happy. Until you have a huge shift in the system whereby patients are taking control of the healthcare system, doctors are taking control of the healthcare system, you're not going to see a change. We're starting to see that now already a little bit because of the recession. When folks are forced to pay their own fees for an x-ray, they would rather pay $100 at the local facility than $500 at the hospital. They're starting to become consumers again. Walmart and Target, which offer $4 generics and medications. Why should we go to competitors where the price of medicines is 10 times higher? So consumers are getting smart. They're shopping around now. I think it's only a matter of time before they catch on.
You raised a couple of questions in my mind, just because as someone who's not, well, I mean, I'm thinking of my own experiences there. One is the more than just a cultural thing. There's a psychological kind of reliance on the system and on medical advice that I grew up with as an old dog that I don't know how quickly I could change. I mean, I've gone to Wikipedia a couple of times to look up, something about one of my blood tests, but that's a real unusual event, and I figure I don't really understand what's going on here. I don't have any medical background, and so I defer entirely as a default, as I am assuming a great many, at least older Americans do, to the medical system and the insurance industry to tell us what we ought to be doing. And I guess the question is there a antidote to that as well? Because it sounds to me like you're suggesting individuals taking more responsibility for their own health care and relying less to a large degree on those systems. Am I right, or am I mistaking what you're saying?
You're right. However, I would argue that it's probably not a good idea to rely on insurance companies for medical advice. Again, they're in the business of health insurance. There's a decision maker who probably is more concerned with saving dollars at the insurance company than getting what's best for you. If you had a clear line of communication, however, between yourself and your health provider, that is, I think, where the money is.
The other question that goes along with that is, to the extent that we're able to reduce costs by virtue of people taking more responsibility for their own health care, what does that do with what I've assumed always is the use of excess fees that I pay in insurance or premiums to help individuals who can't afford it? Or am I just mistaken? Is that all that money going to individuals that are a part of the system, as opposed to people in need of health care who didn't have the good fortune of good health that I did?
If it's insurance dollars that you're paying for private insurance, chances are it's going back to the insurance company.
Let me take a whack at that.
Yeah.
I think everything's getting paid for right now. So you mentioned the $400 x-ray in a hospital. Well, a hospital's paying for, uncompensated care in the form of ER visits that people don't have insurance to cover. So they'll show up at the ER, the hospital will have to take them in. So, our system is broke. And whether it's insurance getting pooled to pay for it, whether it's taxes getting pooled to pay for it, it's getting paid that way. I think the question that you're really asking, I think I hear is, will we, our generation, say, I've got to change, I can't rely on that health care anymore? And I think when that question gets asked, hey, you're pretty smart. You're spending $12,000 a year for one physician. I think when we start looking at that and understanding there's no value, I think when the unions, for example, who have historically had the richest benefit plan designs in the world, they pride themselves on being able to get first dollar coverage, and they can't get in to see their doctor for 6 weeks. They say, well, I might have coverage, but I don't have access. What's going on here? So I think what you'll get is this kind of groundswell of folks saying, hey, what have I been paying for? I can't get what I want, and when I get in there, it's unsatisfactory service. So what technology will do is give an option. So let's take managing cholesterol. Let's take what it takes for you to get a prescription renewed. Let's say you've got the technology to say you want to do that. Typically what happens is you'll go in to see a doctor. You'll have to have that visit in order to get your prescription renewed after 3 refills or whatever it is. And they'll want to do some appropriate testing. Kind of what are your current labs, what are your diet changes, what are the things that need to take place. But those are all algorithms that could very easily be in a self-serve environment. You could very easily do that yourself, get your lab results in an inexpensive way, publish it to your physician so that your physician can just make sure that there's not something that needs to be looked at. And then that report they could go pick up simvastatin for $4 instead of Lipitor for $120 at a Walmart and be done with it, instead of waiting, I can't get in, I got a refill, can you do that? So those are the kinds of transformational changes that I think we will not be happy with. I think most of us in this room aren't going to be happy with the service that the current system is set up to provide us. And so when we start screaming, I think things will change.
Pam, how receptive are the medical profession and the insurance industry to your technological solution to some of these issues that we're talking about?
I think when I talk about my solution, people are like, yeah, that sounds great. That's something we want to do. We're thinking about it. I think to the adoption of technology for solutions, it's confusing. And they don't know exactly where things are headed, how it's going to sort out. So whether you're an investor who's sitting on the sidelines or you're a health plan who's dabbling with it, there's pilots going on, they're trying things out. The healthcare industry has never been known for rapid change, and when you come from a technology point of view, it can be really frustrating because we move really quickly, and frankly, all of a sudden things are really picking up speed in terms of the options out there. And this is causing confusion and fear. We see, quite a bit about which way do we go. Some technologies are obsolete overnight. If you've invested in devices, now all of a sudden it's about smartphones and using them to collect data. So there's investors that have lost a lot of money, and maybe they were building their solutions for 5 years, and all of a sudden smartphones come on the scene. So, technology, there's a lot of good, but it's causing some problems as well. I think there's a lot of confusion around usability of a product versus security. So HIPAA, do you encode every medication reminder that goes out to a phone and make people click twice till they can open up and see the name of the drug? Because somebody might see the name of the drug on their phone, and that's really impedes the usability of the system. There's rapid technologies caused a lack of standards. How do you transfer data between these systems? How do you connect everything together? So it's accelerated, and entrepreneurs like us are sitting here trying to keep up and try to figure out which way do we go and how do we integrate this stuff together. So there's also issues around who owns that patient data and who owns the record. If you get your personal health record from your insurance company, do they own that? And if you leave the plan, do you get to take that data with you? That seems to me like it would belong to the patient, and they've invested in using that. When they leave that plan, should they leave that behind? I think that record should be portable. But those are issues that are open right now. So there's technology challenges. And to build solutions, there's a shortage of engineers in the Valley right now. So it's not that easy to get a great idea and hire an engineer and build something.
Very interesting. You've raised a lot of issues. One though, is new models generally for that are going to be necessary, not only like the one that you obviously have developed and pioneered, Dr. Kamer, but but what other kinds of new business models are necessary to make this all work?
This is working, yeah.
Yeah.
Ours is very new, direct primary care. Concierge medicine is something that's been tampered with and practiced with quite a bit. I think you're limited with the number of markets you can grow that kind of practice in. Sort of coming full circle a little bit and going back to Pam's comments about taking ownership, if you will, of the patient records. One thing I just want to point out also is that in this room, chances are most of us are educated and very much in tune with our health. Most entrepreneurs are. In fact, most of the folks who create new models and new software are as well. We care about our cholesterol. We care about living longer. We care about our blood pressure. We're not really dealing with that population, though, on a day-to-day basis in the practice. Back in the trenches, where we have to educate the diabetic that a hemoglobin A1C of 13 is bad for you, we have to say that at least 13 or 14 times before it registers, so they do something about it. They won't be tempted to invest in technology or even in a $1.99 app if they don't understand what it is that they're buying and how it's going to help them. So I was going to mention John's program in the Chicago City Schools, where they actually educate high school students at a very basic level about healthcare issues to then go out into the community and become advocates is fantastic, because I think that's where the money is also, is education with the patients. Until they understand how to take charge of their own health, they're really not going to follow our companies, our technologies, or anything else. They won't be incentivized to do it because they don't understand it. In terms of other business models, there's been a huge surge with urgent care centers and retail clinics as well. In my opinion, in my humble opinion, retail clinics are growing very quickly because of, again, a lack of access to doctors. I think if you could wave a Harry Potter wand and make all primary care doctors accessible to their patients, overnight retail clinics would not do so well. Right now, they're sort of riding the surf because of the lack of access. There's also a shortage of primary care physicians as well. So there are other models, such as ACOs, that are being regulated by the government, that are trying to incentivize doctors to participate in direct primary care homes or medical homes to try to grow that as well. There are hospitalist groups which are forming around the country. It's been shown in studies that hospitalists, by the way, they're the doctors who stay in the hospital. That's a new trend. No longer does your family physician come to the ER to admit you after seeing his or her patients in clinic. Now, if you end up going to the ER, you're admitted by the hospitalist, a specialist in hospital care. Studies have shown that care under a hospitalist shrinks the admission by 20 to 30% in terms of length of stay, which is great for the hospital because they can keep turning over numbers. So there are many models coming up right now, but I think unless you find a solution, which is going to be tough with the current system, you're going to keep seeing different models come up.
People have, all of you have mentioned at one point who owns the information. John, who does own the information that's collected throughout these various technological models, and how will a patient be best able to exercise her options and rights going forward?
You know, I think this is the answer is I don't know who really owns the data, and it's because the patient or the member has to take it and say that they're going to manage it. And with the culture that we've got right now, where it's a very open access model, everybody who's gone online has basically ceded their privacy rights in some way, shape, or form when they sign the agreement online. So you've got two things happening: a cultural shift where people feel like, I don't have any privacy anyway, and then you've got a reaction, again, a top-down reaction, where we're trying to protect the data in such an onerous way. And then when you start talking about technology, where most technology models are based on a revenue model that leverages that data or aspects of that data, we're unable to deploy the technology in a way where the revenue model supports that growth. So I think we've got those three things coming together. At the end of the day, the consumer's got to say, it's my data, and I will share it based on the quid, kind of what am I getting back in exchange for that. And if the companies can't articulate in a more compelling way why they would, what they're going to do with that exchange of data, then I think the consumer who feels like it's their data will not share it. I think the other piece that's more important, particularly in an insurance environment, if the Supreme Court strikes down aspects of the Accountable Care Act, and the one that is would be most problematic relative to data from a risk point of view is the guarantee issue provision. So if there's a guarantee issue provision, people become less concerned about somebody taking their data and using it against them.
What's a guarantee issue?
Guarantee issue provision means that everybody can get insurance. Right now, in the market system, if you're not a good insurance risk, then an insurance company typically doesn't want you, which is the business model they're in. I'm not saying anything wrong with that. The attempt to cross the chasm, so to speak, with the Accountable Care Act said, well, we want to rely on private industry and the insurance infrastructure to be able to provide health care for all, but the only way we can do that is to insist that everybody can get insurance, that they cannot be denied insurance because of a pre-existing condition or a maximum lifetime benefit or any of the provisions that are typically laced into the old insurance policies that would keep people from getting insurance. So if you take that away, then all of a sudden the consumer is going to say, if an insurance company can deny me coverage now, I'm not sure I want my private information out there because it will affect my ability to get insurance. So it will become a much more sensitive subject because there'll be an adverse impact to the consumer if the data's out there. Now, if everybody's kind of in the pool and everybody's got to do that, then the kind of value of the social media platform that says, how can I get the wisdom of crowds to help me solve my healthcare problem, then there's no economic penalty for sharing it. So I think that's a big issue we'll be looking at.
I know. I talked with Tom about this just a little bit before the panel presentation. Do you have a follow-up question to any of this?
Actually, you addressed it. The main question that I had was really around how do you get people to open up that access to that information, and I definitely agree that you have to have it built into the legislation or the CARE Act to protect people. I guess going on from there, once information is shareable and open, what do you see as potential uses for this data? It seems like in all these applications, services, you're collecting huge quantities of data that could really be useful for understanding trends in healthcare or in informing the patient. I was just wondering if you had any thoughts on that.
Actually, that's a great question for all three. To the extent you didn't hear it, Tom was asking what uses can be made of this data, assuming there aren't the kinds of impediments to gathering it from a privacy, business, or incentive standpoint that would exist. And I think it'd be interesting to hear from all three of you on this because that's a great question that encompasses what SVForum is all about, if I understand it correctly.
Tom, I'm assuming you're referring to data as patients' confidential health information, records, and such.
That also the transactional part around what kinds of information do they look for in using an application like yours. So really broad. It's a very broad question.
We could use that. For instance, right now we're advising a bunch of research students, medical students at Washington University School of Medicine, who are doing a long-term study to see if direct primary care practices end up with better outcomes, better patient outcomes than traditional insurance-based practices. It's supposed to be a 4 and 5 year study, being commissioned by Washington University School of Medicine, and we're just getting to the starting phase of it now, one of the advisors. But that is somewhere where we could use that data very nicely to see if we can indeed affect outcomes. Because the truth is, if we can show, for instance, that high impact preventive primary care in the community can curb downstream admission costs and specialist visits, we've saved everybody a ton of money. The education cuts in California is a perfect example. Most of that money isn't going to Medi-Cal. If we can save the healthcare system here in California, we could probably have less education cuts down the road. So we could use data for that purpose at least in our industry.
So looking at your question on an individual level, we allow people to track any type of statistic. So they can, for instance, my developer is trying to stop smoking. So every time he smokes a cigarette, he just records it on his phone, goes into a chart, and he can see the time of day and when he smokes the most. You have people tracking their blood pressure on an ongoing basis. They compare that against their Outlook calendar, and they can see which meetings actually causes their blood pressure to go up and the time of day where the greatest stress is. Some people track sleep and measure their pain levels by getting a reminder that says, how much pain do you have today? You can start taking a look at, if you sleep better, is your pain less? At the same time, you're tracking your medication compliance and you're reporting, did you take your drug or not? So you can get this in an aggregated monthly report, so you can take a look and say, I notice when I'm less compliant, I have more pain. One of the other things that I set up in our demo is meditation tracking. It's a simple yes or no, did I meditate today? So you get pushed out a reminder, did you meditate, yes or no? It's a don't break the chain type of chart. And oftentimes meditation can impact pain management and stress levels. So you start looking at, as you meditate daily, that some other things in your health might be improving. So on an individual level, you need to get these things all consolidated together. So our vision is, we don't yet do it, but to integrate with some of the leading smartphone apps that do a very good job of collecting this data and bringing it in, and then enabling a patient to see monthly the total report of their health. So on an individual level, it's very valuable. On an aggregated level, that's anonymous data. If you're tracking certain drugs and pain outcomes, you can start looking at how effective those drugs might be and whether they should be reimbursable or if the patient should even be taking them, or what the conflicts might be between drugs and other drugs. So that gives some insight to the community on what should be reimbursed. Maybe these aren't even beneficial drugs, and that could lower the costs. Does that somewhat address what you asked?
It also raises those same tensions that John was talking about in terms of the use of these and monetizing them, and who's gonna benefit from them. Yeah.
I think the big hope for data, from where I've seen, is that if we think about how most data is collected now, I would categorize it as clinical data. There has to be some event, a healthcare event, and then you kind of track that information based on compliance and adherence. And so Pam was talking about was opening up the notion of community, a collection of data, so that you can begin to track how to keep people from moving into a clinical event. There's pretty solid research that would indicate, if you take a look at the continuum of healthcare, from a state of wellness to a state of disease or acute, that there's three big buckets. And once you move from a status of wellness to a status of pre-disease or pre-acute, that you've lost big opportunities for cost savings and health. And if you move from that condition of pre-diabetic to diabetic, or that condition of obesity to complications from heart disease, if you make that leap, improving the health and or reducing the cost becomes much more difficult. So if you think about the opportunity for technology, it's collecting that data that is pre-clinical. What are you doing? What's your behavior? can we aggregate it in a way that says these kinds of social functions actually keep this group of people from moving into one of those states? And I think that's a real hope for transformational change that can really take a look at the systemic stuff. So, and that is not clinical, and therefore is a way that we could get over some of these personal health information issues. So there's my big hope for the technology is take the quote social media, but make it much more about, information on Pam just mentioned, meditation, some of the things that are difficult to document as true cost savings that are impossible to get reimbursed for, really. No insurance company would ever pay for any of that kind of stuff, and make it about your personal health experience.
Although it becomes valuable once the data is collected, and it becomes
absolutely.
It's not patentable, that data, but it's a trade secret. Just to come full circle here, and it becomes very interesting in terms of how you package that and use it. And this is a really exciting area. Obviously, it's the direction of this whole industry. We've gone about an hour. I want to give people an opportunity to ask some other questions if they have them. If not, we can adjourn and you can ask them individually. Yes?
Looking at all three of your separate businesses, it really seems like it epitomizes the problem we have with healthcare. I mean, it's siloed. And it would seem like Silicon Valley or this area could come up with an integrated approach to address healthcare. Would be, I mean, we could set a standard for the nation, but it's going to take collaborations between individuals. Is there any group kind of looking at from a 30,000-foot level, how can I take these pieces of technology and come up with a unified solution?
I'll start with that. That's a great point. You're absolutely right. Everything is compartmentalized. That's part of the reason we're here today, is we can learn from each other's companies perhaps, and see, for instance, if Pam's company could help our patients in any way. I've been thinking that since I read her profile last night, how we can use the technologies in our practice to help our patients get better outcomes. That utopic type of scenario would be very difficult to accomplish. However, I think you're right. Some savvy folks could probably take a 30,000 foot look at the whole thing. We, in our practice, are trying to encompass as much as we can. I've been talking to Johnson & Johnson, their Innovation Health sort of division. They have this pretty cool plan to get diabetics to test their sugars, and if they don't, they get a text message. Because if they don't check their sugars, it doesn't register into this computer system. The doctor finds out. Our medical assistant, after 3 days, we call the patient back and say, we know you haven't been checking your blood sugars, you need to do that. That kind of accountability really helps. So there are companies trying to sort of merge clinical aspects with technology aspects. But that being said, technology, I think, is still so new in health, in the health field right now, that we're still looking at different ways to integrate it. But that's a fantastic point. I think if someone could think of that, you'd have a solution.
I have to say, it's really exciting to be in this space right now, and I was here for the .com days, and it's so similar to me, what we went through at that point, where you had an awful lot of point solutions, one for e-commerce, one for analytics. There was hundreds, thousands of companies here in the Valley, and it goes through consolidation. And so we'll start seeing the consolidation begin to happen. And from our point of view, we're looking at consolidating the smartphone apps and bringing that data into our platform. And we'll then integrate with the EHRs and bring the data over. I don't know who the big players will be that will step in and start consolidating this industry. It'll first start with these partnerships. This is how it goes through. We make these nice, I like you, you like me, let's integrate our solution partnerships. None of us are making a whole lot of money. And then it becomes a bigger and bigger solution, and then they get acquired and bundled together. In the end, from the .com days, most of that technology is now over at Oracle or SAP. So they owned all the solutions that were started, the guys that made it. So it's nice to be here. It feels very much like those days. And how long it takes and exactly who those players will be remains to be seen. Some people in this room might have some insights into how that's going to go, but I'm glad to be part of it, and it's really exciting, and it is a little scary too.
I've got 3 thoughts on that question. Kaiser, Apple, and shall we say life. And I'll take them in these 3 orders. One is Kaiser really nationally has the most well-integrated approach to doing this. They've got the financing, they got the branded name, they've got the integrated provider, they got the technology. But it's a you either like it or you don't like that brand. But they have attempted to go with that integrated solution. I think of Apple, of course, they're the game changer because their leadership and their position in the marketplace was strong enough to say the consumer really doesn't know what they want. I want to make something neat, and I'm going to roll the dice, and they're going to like it. I think we're too fragmented for that, and there's no real kind of apparent leader who really knows that. Quote, the consumer's really going to like that. And the third thing is life. I think, at the risk of sounding a little, airy-fairy, our natural state is healthy. And there are fundamental things that we can do as people that are very simple and not expensive, i.e. diet, exercise, meditation, that really can self-correct. And I think the big opportunity in art is to really use healthcare to create the ultimate sustainable economic model, because the life force that we have, if it's taken care of, takes care of a lot of things. And the notion that we're pursuing outside things in order to, quote, fix us is something that I think we're on the verge of being able to say. If we've got a sustainable body, we've got a sustainable earth, how do we develop an economic model that supports that? To me, I think that's where the innovation is going to come. Somebody's going to step up and say, gosh, do we really need to spend that much money? I'll get where I need for, $59 a month instead of $1,000 a month, and I'll take care of myself. I think that's where the big upside is, but I'm probably alone there.
Another question?
Well, in my mind, it comes down to who is most incentivized to gain in the system. So,
Do you want to,
I
here,
agree.
let's give you one of these so that we can hear you.
I agree with what you're saying about like Kaiser, but the one point you didn't mention is that, and maybe not a lot of people know this, is they hold on to their patients for the longest, right? So they're really incentivized to get into predictive, preventive care,
Right.
and eventually, Dr. Sam, is the same for you, right? As your organization grows, you actually save money, right, by people getting better health. And so that's really the system we have to move to. I spent a couple of years at the NIH. I also have engineering background, right? And the government, they want to solve this problem. They don't know how. And I think what John is saying, it's exactly right, that we'll move to this model. In my mind, the players that might step forward, I don't really look at like an Apple, but maybe more a very consumer products focused company. Maybe getting into the Walmart or CVS, or somewhere where you're going to get your medication anyway, and driving the business from that angle.
Other comments, thoughts, questions? Okay, yes, go ahead.
I think it's fortunate that we can.
Why don't you-
I think it's fortunate that because the privacy laws haven't been codified in the United States, we can look at some of the opportunities that were mentioned earlier. Some of the things you're doing are pretty exciting. But eventually we're going to have to deal with Europe, which has an entirely different privacy framework. And I'm just interested in your thoughts. I mean, I see a potential here for companies like yours in the United States to come up with some great solutions that help the health of people. But then there's going to be a wall when you try to go to Europe with their privacy rules. And I'm just wondering what you think. Have you given any thought to that, or?
I've talked to some of the companies in Europe, and the UK especially is very concerned with this, and there's people over there. I know that they are even more difficult than we are here. And I really can't speak to how that goes, whether the patient has to always opt in, or there's disclaimers, or how they're going to go about that. But it's an impediment to the adoption, and they are struggling with that very issue. They're probably more concerned over it than we are here with the accelerated healthcare costs. And they've got a lot of people just like us sitting around frustrated. So I'm sorry, I just don't have that answer, and it's really frustrating for entrepreneurs ready to go. But you're right about Europe. They're really looking at it. Do you know the answer?
I know nothing.
No. I went there and met him.
Our direct primary care industry is focused on the U.S. right now. There are certain countries where we can think about expanding. We had an international business school in Monterey do a study on us to see the top 3 countries where we would grow the fastest with our model. Singapore, Mexico, and Dubai, I think, were singled out after analyzing 100 of them based on their government/private healthcare models. Right now, we have a big enough country here to take care of, so we're going to concentrate here first. We are looking at Europe very closely. There are some very disgruntled patients out there who don't feel the government takes care of them well enough, and we're seeing if we can infiltrate those markets down the road. But right now, we have a big problem here in the States.
Oh, I think we're going to wrap things. One more question, okay? One more question.
You know, I want to follow up on the compensation question, and I'm sorry I couldn't get out of my meetings to get here earlier. But my question really is to follow up on the incentive piece. You know, I agree with Pamela on the whole, what we saw in the earlier .com days, and I was there and had a company. And, the problem is, I think the innovation comes from small companies that think differently. And yet, if I'm really realistic, and I'm doing a startup, but I have to say, if I'm really realistic, I think that we may not get the opportunity to solve enough of the big problems for startups right now. In other words, you need a certain runway to get your product out, and I just hope the funding market is there for us. But my question really speaks to the issue of compensation of docs. So we'll build all of these consumer-facing apps and relationship management apps, but currently physicians are not incentivized to participate. And so what we're doing is we're rolling out thousands of fitness apps because we aren't reliant on physicians for them. But I think some of the most innovative applications I see are in the fitness space, not in the healthcare space. I think Google Health taught us that rolling out a PHR, a personal health record that looks like an electronic health record is not the solution. So, building a more consumer-focused product, the problem we have, I think, is then how do you engage physicians and other healthcare providers who are not paid to participate on those platforms, even though the service they're delivering might be incredibly cost-effective, might be keeping people out of a readmission when the hospital isn't going to get paid for the service, maybe, supporting them in disease management, not even in prevention.
I'll start with that, if that's okay. One of the reasons we're growing so quickly is because we do incentivize our physicians to take care of our patients. Our family physicians, who on average in the current system start out, when I graduated from residency just about 6 years ago, the starting salaries were about $90,000 per year. My wife had about $250,000 in loans. I had $300,000 in loans, and $90,000 a year for each of us just to cut it. Our doctors now at capacity, and when I say capacity, they still see half the national average of patients per doctor. Our doctors stand to make in excess of about $500,000 a year. That is a great incentive for them. We actually have a program right now being launched to all residents around the country graduating from family medicine programs to help them start their own practices and even do some loan payment options for them as well. In our practice, we like apps. We want to find the ones that work and see if we can include that into our monthly membership fees, if we can incentivize the patients to pay for that. In our practice, we don't mind seeing the patient for half an hour to educate them, because we don't have to see 30 or 40 patients a day. We get paid at the end of the month anyways, so we can spend up to an hour with our patients, educate them about fitness, about exercise, about nutrition, and see better outcomes. We think that's the way to go. Unless you do something about incentivizing physicians to take care of patients, they're just going to get stressed out and they'll leave. And then the patients themselves will be forced to look for places like apps and fitness centers to do something about themselves. So that's what our model does, and that's, I think, why we're growing so quickly. Yes?
What about compliance on the patient's part? Do you ever fire patients?
Of course. We don't.
Sorry.
we don't change the boundaries of the patient-doctor relationship. They're exactly the same. If our patients are non-compliant and we feel that we can't get through to them as providers, whether it's a failure on our part or their part as non-compliant patients, then we end the relationship. But absolutely, we let go of patients in the same way that an insurance company paid physician would. Going back to the hospital thing with readmissions, we just right now are signing a contract with a very big hospital in Monterey, Salinas Valley Memorial, I'll mention their name. They see something with us in helping to prevent readmission rates, which they could get penalized for if patients who are discharged get readmitted within the month. They're actually taking up the fees. They're going to start paying for Medline fees for their patients who get discharged without assigned doctors or for patients who don't have insurance. And when they do that, they save themselves quite a bit of money down the road, and patients are healthier. Patients that at the end of 3 or 4 months have a choice whether or not they want to stay on with us. When our fees are so affordable, they usually will, I think. But that's another way we incentivize our doctors as well. I'm sure you have comments on that.
You're starting to sound like an insurance company, Sam.
No. Comment.
That's a great job.
I'm out of words.
You know, in a fee-for-service environment, we have historically tried to solve our problem by cutting, you know, the rate we reimburse people. And what we've done is created a mess. We started in the work comp arena, and we started not paying people for their service, any number of them, and what ends up happening is they just provide more units of service in order for them to reach their number. And of course, what's happened now is people are backing away from taking new patients that don't pay enough. You got Texas, half the primary care physicians down there won't take on new Medicare patients. So you may have insurance, but if you don't have access, you don't have anything. And so it gets back, I think, to the consumer saying, what do I want, and can I buy it directly? And let me buy insurance catastrophically so that I've got that coverage should something happen. But this kind of personal relationship with a healthcare provider and paying them in a way that doesn't create perverse incentives on either side of that transaction is what we need to move to. And I think, in fairness, the ACO provision of the Accountable Care Act, this notion that Medicare would start paying a global fee and let the physicians transform their practice and then keep the savings, that was a noble attempt to try and change the compensation program. But to your technology question, we've got a big challenge in terms of monetizing technology. And every technology startup out there relies on an ad model, typically, to monetize the technology and grow it into the marketplace. And when you've got a small consumer base, which healthcare users are small as a percent of the total, and private data, there's not much to monetize from that standpoint. So I think that's why you see wellness apps playing well. It's not in that clinical side of the business, and it also is something that advertisers can participate in to help monetize that technology.
Terrific. Listen, we could probably go on all day. We do really have to close things down. I want to thank Pam and John and Dr. Sam for a terrific presentation. It's really an honor to be a part of it. Thank you very, very much.